Who does not know the next speaker, Madam Dr. Prema Ramchandran? But still, it is a matter of great pleasure for me to highlight a few of the facts from her very detailed biodata. Dr. Prema Ramchandran, Madam, graduated from Madras Medical College. She obtained MD degree in obstetrics and gynecology from Madras University, and she was university ranked 1, topper. She has been a fellow of the National Academy of Medical Sciences since 1986, and she is a past president of NAMS. She worked for the Indian Council of Medical Research for 25 years, from 1971 to 1995, carrying out clinical and operational research studies. She coordinated ICMR serosurveillance for HIV infection in India, and this activity provided the database for evolving the National AIDS Control Program. She has worked as an advisor, Health, Nutrition and Family Welfare in the Planning Commission from 1995 to 2002. She is currently working as Director, Nutrition Foundation of India since 2004. She has many other contributions, more than 200 papers. She has prepared country report on dual nutrition burden in India for the FAO. She completed a report on nutrition and HIV infection in Southeast Asia countries for WHO Zero 2011. She prepared the report on nutrition transition in India for the Department of Women and Child Development, and there are many others, and I will respect her wish to be brief. And now I invite Madam Dr. Prema Ramchandran to begin her lecture.
Thank you, Dr. Vanda. In a way, Dr. Kutwat has laid the basis and the rationale of every actual reality that we see as nutrition transition epidemiology in India. And therefore, my job will be much, much easier, and I'll be able to relieve you to go to the lunch by about in another 25 minutes, I hope. We can reserve the questions for the afternoon sessions if there are any left over after discussions during the lunch hour. What two major changes that have taken in the world in the last 50 years? One was that globally there was a growing recognition that developing countries are now becoming as sedentary as are the developed country people, and therefore they are going to have a major problem in terms of perhaps requiring less energy, but finding it difficult to change from what they were used to do. It's very easy to become inactive. It is not so easy to reduce your food intake by half. That takes a lot. The second is, all that Dr. Kutwat had shown, he had emphasized the changes in energy requirement from two factors, one change in BMR and the other essentially talking about activity related and how by multiplying BMR by different value you'll end up. But much more than that is the biggest elephant in the room, which we have been debating for a long, long time without resolution of it. What body weight? Reference man, 60 kg. Actual height of this guy and actual BMI that is desirable in that. If you take that BMI of 21 is desirable and the woman has a height of 151 centimeters and the man may be 162, you would land up with a reference body weight for all Indian adults as being 47 kg for women and 52 kg, 53 kg for men. Straight away, the requirement drops down. The table already exists. It has been sanctified WHO, everybody. But we do not apply it because our reference man is heavier by almost 10 kg. Reference woman is heavier by another 10 kg. And when you take their body weight, this is 20% of their body. This is the actual elephant which should not be forgotten. Requirements are basically multiple of body weight, and that has to be taken in mind. Why did we err so much on the side of putting more energy? It is a measure of caution. If you remember Dr. Gopalan, the scientists of the era before 1980 were born and brought up in an era where 70% of India's population were poor, were food insecure, were undernourished. It really sets your psychological mindset. And we are human beings, therefore they wanted to protect these people by erring on the side of caution. But unfortunately, times change. When times change, we are now getting into a situation of, we now understand energy requirements should be the basis. Energy requirements are lower. Indians require less energy because they are smaller. They have more fat for a given BMI. And physically we are becoming inactive. So a combination of factors literally makes our energy requirement drop down by perhaps a factor of 30%. It's a terrible thing to see. And that is what Dr. Sashikaran in his inimitable style said, eat half. How easy is it? Very difficult. Apart from that, the major focus of global and national efforts in MDG was to reduce undernutrition, undernourishment, low dietary intake are all mentally synonymous to development plans. We have other connotations. We use different indicators. They also felt communicable diseases and maternal child health formed 60% or more of their disease burden, and so that should be combated. So, what did they do? They set the targets for developing countries to achieve the goal of reduction in these problems, and we must acknowledge one fact. Globally and nationally, the period between 1990 and 2015 witnessed the steepest fall in the prevalence of undernutrition. Never has that much fall been achieved. And it didn't come from international funding. It came from every national effort of every developing country. Morbidity also came down, not so drastically. There has been substantial improvement in maternal and child health. So now you are seeing the big 60% shrinking into 30%. And there is no vacuum. What comes to occupy it? Non-communicable diseases. The tragedy with the non-communicable diseases is that these are things that require early diagnosis in an asymptomatic phase. Diagnosis is difficult. It calls for a lifestyle discipline change, which is not easy at all. Lifelong medication, God, we all know how difficult that is. So this is the change that has happened. And what does the SDG do? SDG, the biggest contribution is clear recognition that in the post-2015 era, there is a dual nutrition burden. This is a reality. Currently, both undernutrition and overnutrition are major public health problems. There is a need to take up programs to combat both these. And also, SDG recognized ongoing health transition. Both communicable and non-communicable diseases are there. Nutrition interventions aimed at prevention, early detection and effective management of overnutrition are going to be the single major factor which will enable prevention of non-communicable diseases. So nutrition perhaps is more important for health in this scenario than it was in relation to undernutrition infection relationship. They also recognize each country will have to prioritize its interventions and deal with it. What are the targets that they set? Clearly for undernutrition, 30% reduction in low birth weight, improvement in exclusive breastfeeding, 40% reduction in stunting, reduction and maintenance of wasting to 5% or less. The other side is overnutrition, and for that they have set goals, which is prevent the rise in child overnutrition, halt the rise in overnutrition in adults, halt the rise in diabetes, and taking into account the national priorities, either halt the rise in hypertension or achieve a 25% reduction in prevalence of hypertension. A 30% reduction in the population mean sodium intake has also been put in as a nutrition goal in the WHO action plan. Let's look at these. The target one is 30% reduction in low birth weight. Dr. Paul has already explained this is not possible. India still has the highest global low birth weight rate, as well as being the home of the largest number of low birth weight infants. There has not been much change over decades, but remember this fact, and every time we think of Dr. Shanti Ghosh and her contribution, we should think of it. Our low birth weight rate has not altered, but look at what has happened to infant mortality and under 5 mortality. Significant reductions have been achieved. We missed the MDG goals by a fraction of a millimeter. There is no reason at all why we will not be able to achieve the mortality reduction goals set in SDG, though we cannot really alter the high low birth weight rate. Why is this? Because our infants are born at term, they are short, they have low birth weight, but they are also highly fat. Provided they are given breastfeeding, which is almost universal in the country, minimum neonatal care and prevention of infection, they will survive. And this is well borne by the fact India, as far as under 5 mortality rate concerned, comes along with the rest of the similar developing countries. Target 2. This is something I think we should feel very, very proud of. This is one of those things in which, are we the topper anywhere in nutrition? Oh, here it is. We give the best start in the first 6 months in the whole world. But should we rest on our laurels? Of course not. What should be our aim? We should again emulate 75 to 80% exclusive breastfeeding at 8 months. So therefore, if this is true, what Chhattisgarh can do, the rest of India should aim for, and therefore we should remind the leaders, and our target should be to achieve by 2025 almost universal exclusive breastfeeding rate. That is the best gift that the mother can give to the infants. Target 3, achieve a 40% reduction in stunting rates. India has, of course, the highest stunting rates, highest number of stunted children. If we use the past as any indication, as a prediction for future, the rate at which we are able to reduce stunting has been historically for the last 4 decades 1% per annum. Should we rest on that and say, itna hi hoga? I think we should not, and this is what Dr. Paul was emphasizing. We can double it if simultaneously we find the wasting goal. But the aim of 40% or 4% reduction per year is impossible. The Poshan Abhiyan aims at 2%. So this is a compromise which India can achieve and should strive. And how do we make up the stunting rate reduction go up? It is by attacking wasting. You also saw some of you who have been seeing these blue-knickered boys that Deepthi drew for us in 2004. That's one thing that I have never ever given up. Anytime I talk on nutrition in children, I always use it. But that concept has now percolated. That essentially, even though we have a high level of wasting, one of the highest levels in the world, we have, as compared to underweight rate, which is 40%, our under 5 children have under 20 wasting rate. Attack it seriously. Prevent the further increase in wasting rate that seems to be happening in girls and boys in the 5 to 9 year age group and girls and boys in the 10 to 18 year age group. If we prevent these, the overall rates will come tumbling down, and there are huge interstate variations. We should all become J&K or Himachal or even Punjab. And if we try to achieve a 50% reduction in those states, it's very, very possible for us to keep in these states 5% wasting and maintain it at that. What will be the side benefit? If we manage that, stunting rate reduction will go on. What about the next? Ensure that there is no increase in childhood overweight rate. We have to accept and understand children of different weights can have different heights. Both these children are obviously underweight. This child is also stunted, but all these 3 children are overweight for their age and height. All these children should do their level best to increase their physical activity so that they lose the adiposity. We also have to understand this other fact. We need not worry. India has very low rates. This is often cited. No, we don't have high overnutrition rates. But life is not only rates. Life is also numbers. And look at what has happened to Southeast Asia region between 1990 and 2050. 3-fold increase in overweight children number. We are in fact the largest region with largest number of overweight children in the world. Unless we act something right now and prevent any further increase in overweight children, we are going to land up in serious trouble. Very often, there is a statement that adolescent weight, really overweight, is increasing in India, and it's a terrible, terrible thing. Small urban surveys, millennial surveys, centennial surveys, that which we see in our own households are all telling you, it is happening. But look at national surveys. We still seems to be having an opportunity in relatively low overnutrition rate in children. And that is children beyond 5 years of age, school age children. We should use this opportunity. We should encourage physical activity so that appropriate steps can be taken at all levels to ensure reduction in overnutrition, and this will go a long way in reduction of adult overweight and NCD related problems. Halt rise in overnutrition in adults. Briefly run through these slides. This is Dr. Sachdev's work, which showed that over 20 years, when there is no improvement in birth weight in their hospital, the fat fold thicknesses have gone up. This is NFI study which showed that high-income school children had the highest body fat content as compared to any other race in the world. Dr. Srinath Reddy's and Dr. Shanti Ghosh cohort study which clearly showed children cross their BMI norms are at greater peril of becoming obese, developing hypertension, and impaired glucose tolerance are across all age groups. So, there is undernutrition and overnutrition are both capable of triggering on an overnutrition epidemic in the adults. We should therefore treat both with equal respect, do what we can to ensure that children do not become either underweight are overweight. And this is the best way we can halt the rise in adult overnutrition rate. What is happening to adults? I am again taking the National Family Health Survey. Reduction in undernutrition, increase in overnutrition. One matches the other. This is really terrible. As I said earlier, the health hazards of undernutrition is far less in adults as compared to health hazards of overnutrition in adults. It's happening both in men and women, and the NFHS 3 to 4, which is a decade, has witnessed a doubling of overnutrition rate. This is absolutely unacceptable. It has to be stopped at all costs. We also have to look at the effect of nutritional status and age. When they are young, they are undernourished, so they give rise to low-weight babies. And when they become older, they become overweight. They ignore weight gain as in their 40s and 50s. A normal है, छोड़ दीजिए. Never go for any health checkup. So unless they land with complication, detection of NCD is an impossible. There are huge interstate differences in prevalence of overnutrition. And what is worrying is, look at all the states which have high overnutrition rates. These are also the states where longevity is high. So straight away you are walking into a double trap. Obese women, obese men, living until they are 80 and 90. Really a misery to themselves and to others, because nothing is detected early. There is nothing to worry if we have early detection and effective management. So we need a real two-pronged approach to do this. In men also, again, there is some understanding that there should be screening, but basically it is not being done as a routine. Some industrial concerns, some concerned state government officials, some police department, army. But life is full of armed janata who form 80%. They ought to come into this if we have to get the public health. Significant reduction. I halt the rise in diabetes and hypertension. Well, as I said, the biggest enabler is reduction in overnutrition. We really need to reorient and gear the Indian health system to successfully get into screening, management for prevention, early detection, and effective management of non-communicable diseases. Dr. Reddy, your slide is acknowledged. This is the way forward. Assess nutritional status, screen by anthropometry, detect both under and overnutrition. Assess dietary intake and physical activity. This has to become a part of everyday medical practice in hospitals, public health practice wherever we go. Effective management of health burden is appropriate nutrition education, care and monitor improvement, assess health problems, provide appropriate affordable health care. There is nothing new in it. Dr. Paul emphasized again and again. What I'll say, there is nothing unknown in it. There is nothing unknown. There is absolutely lack of awareness as it applies to you, me, and the woman in the house. We need to apply this knowledge, ensure that everybody has access. We, at the moment, do not have a universal screening system, so we should begin assessment of nutritional status as and when there is an opportunity, when anybody comes for anything, to either a nutrition setup or a healthcare setup. Once the assessment is done, this is also a message that we should get. Normally nourished person, bahut acha hai. Aisa hi raho. This is the right way for you to go on. Promote your current lifestyle. We will support normal nutrition and health status in you. Those who are under or overnourished, provide appropriate nutrition and physical activity counseling. Finally, there is a group with illness. Identify nutrition problems, provide appropriate health and nutrition therapy, restore normal health and nutrition. In every case, once cross-sectional, when they came to me, approach has to stop. There has to be a continuous monitoring, and for this we need the cooperation of the population. Luckily, we have an aware population and we should use them very well. Nutritionists and physicians should work together and synergistically if we operate. The SDG goals for health and nutrition are certainly not beyond our capability. What is the take-home message? Ultimately, this is what I want you all to remember. More than 80% of underfed children and 50% of adult population in India are normally nourished. It's our bounden duty to keep them normally nourished. We should endeavor to see they remain normally nourished and healthy right from childhood through adolescence and adult life. Then we will have healthy, happy India, which will enable the country to progress towards. Thank you very much. We will take questions after Dr. Srinath Reddy's presentation because a large proportion of things that I talked about, he will elaborate and he will provide the answers to most of them. Incidentally, it is also lunchtime. You do need some energy. Okay? Come. I'm now going to get what the Jena is and where they go. We now adjourn for lunch. This is 1:45. Can I request you please to come back here by about 2:15? Please and come back.